Okay, good morning, good afternoon, good evening, colleagues and friends, and happy Sunday.
So today I'm talking about transplant glomerulopathy, a pathologist view, because I'm a pathologist. Transplant glomerulopathy is a disease pattern of injury. It's not exactly a diagnosis by itself, it's a pattern of injury. And it's characterized or defined by glomerular basement membrane duplication. And typically when we are talking about transplant glomerulopathy, we are talking about it by definition in the absence of immune complex deposits. I'll show you some pictures of transplant glomerulopathy here. This is in a silver stained section. We can see glomerular basement membrane duplication. Remember the basement membrane stains are the best to appreciate this. So that would be on routine cases, the silver stain or the PAS stain section. So you can see here glomerular basement membrane duplication. You can also see some marginated inflammatory cells here, which are mononuclear cells, and some enlarged endothelial cells. And speaking of endothelial cells, occasionally you can see, like the arrow is pointing to here, endothelial mitotic figures. And that also shows you that this is really an endothelial disease. And look here, this particular glomerulus, I saw it the other week. It has two endothelial mitotic figures in a single glomerulus. Now, by electron microscopy, we can see glomerular basement membrane duplication, which the red arrows are pointing to here. And also, I had talked about endothelial cells being activated. You can see this large endothelial cell with loss of fenestrations that the blue arrow is pointing to. And just for comparison, here's a normal glomerulus where you can, with the green arrow pointing to normal endothelial cells with preserved fenestrations. You can see how enlarged endothelial cells are in that case of transplant glomerulopathy. And here's a more severe transplant glomerulopathy where you can see the original basement membrane out here in the glomerulus, and all of these layers of basement membrane that are being formed. And here is a tiny little lumen here. So this is a severe case of transplant glomerulopathy. So most cases of transplant glomerulopathy are due to chronic antibody-mediated rejection. And we think this is because there is chronic or episodic antibody-mediated damage to the endothelium. And when the endothelium is damaged, it likes to repair itself, and as part of that process, for some reason, lays down a new basement membrane layer. Now, today I'll be talking about this classification system, the BAMP schema, which is the most commonly used in transplant pathology and in rejection. And to diagnose chronic antibody-mediated rejection in the BAMP schema, we use these three criteria. First is histology, which is chronic tissue injury attributable to antibodies. So that would be, for example, transplant glomerulopathy, which would be the most well-recognized form of chronic antibody-mediated rejection. Second, we need evidence of recent antibody interaction with the endothelium. This is usually C4D, but we can also use peritubular capillaritis and glomerulitis as evidence of that antibody interaction. And third, donor-specific antibody, or TSA, which is usually against the HLA expressed on the endothelial surface. So what we think is going on in C4D positive antibody-mediated rejection, at least in the acute setting, is that we have the graft endothelium that's expressing the HLA. There's circulating donor-specific antibody that recognizes that HLA. That antibody then activates complement by the classical pathway. And eventually we end up with complement-mediated endothelial injury. And where does C4D fit into here? Well, C4D is a split product of the complement component C4, and it binds covalently to the site of antibody activation of complement. So in this case, the endothelium. And it stays around for about 1 week after activation of complement. So it's a good marker of more recent